I think it's a very apt topic because every day I think is a new challenge, a new beginning to the day. So this is the topic that has been given. So at the outset, I'd like to thank APPI, the organizers, for giving us an opportunity to come here and share our experiences, what we've learned in the last 25 years of our career. With 21st century, of course, there is so much of new developments. There's a shorter TAT, there's a faster TAT. Quality has been the main focus of everybody's talk, right from the accreditations and things like that. So quality stands, tall. And of course, then you have a higher output or throughputs of the equipment in terms of automation and faster TATs as well. We are going towards evidence-based medicine. I think this point has been very well highlighted in the clinical, any meetings that we have with clinicians, because without evidence-based medicine, especially oncology, you are liable for a medical suit. So that's why they need a lot of documentation in terms of the diagnosis, the reports, histopathology, microbiology and lab reports, without which they are handicapped most of the times. So with evidence-based medicines and guidelines such as IDSA, Infectious Diseases Society of America, they have standard guidelines for all the infections and especially hospital-acquired or device-associated infection. That's how we need to give them faster and better reports. I think the next 2 points are the most important points that we find that in 21st century, that's where we go. So I think all of us together are common on one thing, that without communication with both sides, so the patient and the clinician, we do not stand a chance. So our communication has to be very strong between both the groups. So as Shankar said, you have to value add. What value addition is to the patient's management is most important in terms of your good reports, in terms of your accurate reports, how they can better their services to the patient as well. 21st century has brought along with it a lot of new things. One of the new things, of course, in our branch is the resistance mechanisms. A lot of resistance mechanisms, and that's how the new technology is helping us to identify, understand, simplify, and work towards it. The new catchword for microbiology is bioterrorism. This century, we are seeing a lot of in the West especially, bioterrorism we all know about the Twin Towers and everything, so it's very much there. It is not that it's been wiped out from the globe. So bioterrorism, especially, in fact, when we were studying also, we were asked this. Smallpox, which was there in the repertoire of the CDC, has now been taken away by the terror group. This is what they say. So smallpox, we do not have any vaccine right now, nor are we having any innate immunity to that. So that is the level of bioterrorism that we are looking out for in the future, in the coming years to come. Of course, in microbiology, there is a lot of scope for clinical research, clinical trials, huge potential there for all our colleagues there in terms of pharma or in terms of any other agency whom we can tie up with, especially the ICMR. ICMR, Indian Council of Medical Research, has got a lot of funding for doing good microbiological studies as well. So microbiology now is coming up in that way. And as telepathology, how important telepathology is today. Today, telemicrobiology is really going up the scale, because in the smaller tier 2, tier 3 districts or the states of India, we can help them by doing telemicrobiology. So this is the 21st century, what it has come with. And of course, what do we say? Automation. Body fluid, blood cultures, everything. You all have the automated systems with you. We were introducing ourselves just about some time before we started. So automation, I think, has changed the whole scenario of microbiology when we were students and what we are now. Faster identification, multi-TOF can give an identification within a few minutes to half an hour, 15 minutes to half an hour is what is claimed, and which is so true. In fact, Hinduja has got a multi-TOF. So you were talking to Dr. Kamila last week, on Thursday, and she said that it's really so interesting now to work in microbiology because you are getting the diagnosis so fast. The clinician is able to help, the patient treatment much better. So of course, when we were students, we had, for antifungals, we used to send it to PGI Chandigarh. Because at that point in time, Dr. Aruna Lok was the only one who was doing it. But today, with Vitech, we are able to identify the Candida species as well as the sensitivity. Especially Trichosporin acini. Acini, there is no sensitivity. Candida auris is the new bug on the scene, where we don't have any sensitivity in terms of the card, because that is a very recent organism that has been studied. Of course, molecular biology, molecular pathology is goes hand in hand, right? From the fish technique to all the the serology, immunology in terms of the PCR, and all the new technology is PCR based. Whether it is biofire, whether it is a gene expert. So molecular microbiology is here to stay for a long way. So coming to the molecular microbiology, the resistance mechanisms in terms of what is the genetic interpretation and the mutation is being very well studied, and that has really helped, especially in TB. In TB, I think the whole patient classification from an MDR to XDR to PDR to DDR is only on the basis of this genetic resistance mechanism pattern. So of course, from the specimen, when you are able to get a diagnosis and very fast within few hours, as he said, 6 hours. So I think that changes the whole scene. Gone were the days when your cultures would take more than beyond 72 hours. With automation, it has come down so much more, and the advantages are so much more. Now coming to this, from the specimen of CSF, you are able to get the viruses, the bacteria, all the panels actually in biofire, which has really helped. So in Nanavati Hospital, our management, this current budget is seriously thinking of acquiring a biofire, because that will really help, especially neonatology. In pediatrics and neonatology, and especially in the ICU. These are the two ends of the spectrum where we have found that a lot of requests have come up of late. The labs are moving from the ivory towers to the point of care. So point of care in terms of rapid serology, rapid identification, tests, one-stop test, so to say, that is now coming up in a big way, and integrated labs. So all of us today, whether pathology, microbiology, we always say that we are a part of Department of Lab Medicine. So Department of Lab Medicine includes all of us, and together as an integrated lab approach has made a lot of difference in the clinician's mind also, that we are not separate. We are complementing each other in all that we do. The other side of it is that quality comes with, at a price. So yes, our patients are paying more for it. But at the end of the day, as one of my colleagues, Dr. Sanjay Gupta, Mediwave, he has a lab here in Mumbai, in Andheri, he said that the intent is very important. Your intent to do good work for the patient is more evident. So yes, the cost is high, but if we can help the patient decrease his final bill in terms of not getting, the wrong antibiotics, would really help the patient. So this is what 21st century has come with. So of course, the challenges are multiple today, because we start off with drug resistance, because that's where our forte is. So drug resistance in bacteria, at one time, 5 to 7 years back, when we had one ESBL organism, that is extended spectrum beta-lactamase producing organism, it would create a stir. In conferences back to back, we had only papers of ESBL. And what was the ESBL, in this institution versus that. So today, nobody talks about ESBL. It is so much accepted that this is a part of my community, it is a part of the gut flora of the patient, it is a part of all of us to stay here. So we don't talk about ESBLs anymore. So the resistance in bacteria from ESBLs to OXAs to AMP-C, to the different things that we were all, this was our theory paper, so to say, the mechanism of resistance in organisms. So finally we land up with mycobacteria, because resistance in mycobacteria has increased a lot, and we are now today being able to do whole genome sequencing, which I think is a big leap, a very big leap. And India, world over, people are funding TB research, as we just said about ICMR in some time back. A lot of funds, US grants are here for, especially NIH, National Institute of Health USA, their grants are here. Yesterday Amita Joshi also spoke about it. A lot of her work is on research grant given by US government to work on TB, because there are a lot of resistance genes that have been detected. Because we detect, when we label the patient as MDR, on two things, either rifampicin resistance, that is RPO, or you have INH rifa, both. So INH is CAT gene. So all this is done with the help of molecular biology today. The older drugs, at Barack Obama, when he was in tenure, he had given the slogan 2020, 20 new molecules. Any of the conferences we go to, we heard only one thing, that pipeline is dry and no antibiotics coming up, bad bugs, no drugs. That was the WHO slogan as well some time back. That particular year, WHO had given that slogan, bad bugs, no drugs. So colistin, which was an older drug, now has been modified because it was extremely toxic at that point in time. So now they worked on it, made it more synthetic. So therefore the pharmacokinetics and dynamics of the drugs have changed. Now we are understanding them better. So the team of people is not a microbiologist alone. It is the lab medicine, as we just said, we are integrated, that's one. Second is the clinical pharmacologist and the physician. So together we are able to help the patient as a team. So multi-drug resistant organisms, MDRO, what do we say? Now ESBLs are passé, we don't even talk about it, because for ESBLs the drug of choice was carbapenems, which is imipenem, meropenem. Now we have been using them, well, overuse, misuse, judicious use, I would not be able to say on that. So now we are landing up with another enzyme, which is carbapenemase enzyme, which breaks down the carbapenems, and so now we have landed up with a CRE, carbapenem resistant bugs. So that is where we are today. In my hospital at any given point in time, I have at least 10 to 15%, I think I would be understating that, maybe more. So this is all that, so CREs are very important today. The cost of healthcare has gone up because of a resistant bug like a CRE. So more number of immunocompromised patients. I think the change has come in 21st century because at diabetes, capital of India, 2050, right? That's what is being predicted. Immunocompromised HIV, of course, now we're not even talking about it. With antiretroviral therapy and good nutrition, lot of education. So HIV is really in the background. Today, apart from diabetes, what we are talking more about is other endocrine disorders. Thyroid. Thyroid disorders have come up in a big way, where we at one point in time, we were not even saying that they were immunocompromised. But all endocrine disorders have got a lot of potential for being immunocompromised patients. So apart from oncology, I think those routine lists will always stay. Transplant. Most of the corporate hospitals now are doing, including our municipal hospitals are doing kidney transplants. When we were students, we had cadaver kidney transplants, ZTCC, Zonal Transplant Coordination Center. We had our seniors who were also as a part of ZTCC, and so were we, because we did HLA then. So transplants have changed the whole scene. Infections and transplants is a very important topic. That is the topic for all the CMEs in terms of critical care conferences. So in infections and transplants are important because whatever seems to be non-assumingly commensal or contaminant can become pathogen and can be fatal. So that's where we have moved towards now. So liver transplants, cardiac and kidney is what we've got licensing for at this point in time. I think the borders are diminishing. Geographical travel has increased, and with all of us being one, medical tourism is in a big way in all over the country. This is for the whole country. It's coming up in a big way, a lot of revenue for the hospital, huge potential for helping our the whole world at large. With them is coming a lot of infections which were probably was in the books earlier. We never saw Chagas disease here, but if you have a patient from Africa or South America, you have to keep that in mind in terms of sleeping sickness. So parasitology has changed. So today veterinary parasitology, medical tourism parasitology, and the local flora cytology, parasitology is now together very important when we are talking about parasitology. Histopathology, microbiology complement each other well in terms of parasites. And we are here for quality. So we have accreditations to help us guide our labs in terms of what is right for the lab, control strains. You have standard guidelines for doing sensitivity tests and interpreting the results. So you have CLSI, UCAST. So all of us follow CLSI here in this part of the city. A lot of us are following CLSI. UCAST is a little more stringent guideline, which is the European countries which are following them. So I think this point was there before, after we meet today and even tomorrow. That is the pre-analyticals. The challenge is in pre-analyticals, because this was and is there today a very important part of our reports. So many times, this is what we saw, including our own lab. The junior most person is given to phlebotomy as a part of lab medicine, isn't it? As a part of the integrated science that we are together in. So we found that they need to be supervised, especially blood cultures. You need to teach them. So if all of us are having a microbiology setup, please give importance to this primary basic level of pre-analytical, because that's where all the errors is, and that's, like how Shankar is an NABL assessor, he'll say that that's where, more than 30 to 35% of the error is in the lab. So in microbiology, the subject is so beautiful because you have a lot of, mixed flora everywhere in the body. On the skin, in the throat, in the sputum, you'll always have admixed with the normal flora. That's very important to then differentiate how is it going to be pathogen versus normal flora. So therefore, patient clinical history is very, very important. Without clinical history, please do not go ahead with the processing, because the interpretation then you will be stuck there. So please ask your clinicians to please give you detailed history of the patient, especially in urine. What we find is, if it is catheterized urine, you have to be very sure that whatever you grow can be a biofilm, because organisms produce biofilm, so therefore you can have resistance. So that is how your interpretation may change. So suprapubic would be an invasive procedure in the newborn, in the pediatric age group. So you have to be very careful in processing those samples. So of course we process them ASAP without delay once they reach the lab. Vaginal swab, you need to have a score, because it has got normal flora to tell you whether it is a bacterial vaginosis or a vaginitis. Vaginitis needs a proper treatment, whereas vaginosis you have totally different way of medication and counseling as well. Blood culture. I think the most important samples that come to our lab, ranging from top to bottom, would be urine specimens, respiratory sputums, most of the times that we have that. And then third and most important is blood culture. Stools and all come really down in terms of, routine samples for culture. So blood culture, a couple of words on this blood culture in terms of its collection and how do we go about it, because that is where you need expertise. So paired samples are mandatory for blood culture collection. So the algorithm that we have in the lab is, the minute we have the sample, we either for serology, which is done on respective days, because all serology may not be possible every day, right? So you store the sample, separate the serum, store the sample. For all the other specimens, you need to process in terms of microscopy and culture, isn't it? So microscopy is the primary finding which have to be given to the clinician, because that will help in terms of his decision on helping the patient for antibiotics and things like that. Then finally, the diagnosis gold standard always remains the culture and its sensitivity as well. So this is the algorithm. So coming to blood culture, QMITEC. These guidelines are from ASM, that is American Society of Microbiology, and they have given guidelines on how do you do blood culture collection. So these guidelines were published long back, hold true even today, right? Blood culture collection is a procedure. It requires assistance, because you have to wear sterile gloves. Somebody has to open it and give you, like a procedure. So please, for a blood culture, please ask for someone to help you out for the sample collection. So recommendation for pediatrics. For adults, it is quite standardized, 10 ml. But for pediatrics, you have a range, because that depends on the weight of the baby, right? The hematocrit and other clinical conditions, because you don't get the veins. You have to do a drop collection. So therefore, it is very, very important in newborn, right from 0.5, and then it goes up to, pediatric age group is up to 12 to even 16 years as is said now. So it depends on, the age of the baby and the weight of the baby, how much you can go. But yes, minimum is 0.5 ml in a pediatric bottle that is commercially available. Bloodstream infection, yes, you need paired sample. Now we are talking about adult. Adult more or less is quite fixed. Adult criteria is pretty genuine, and across the country it is the same. So it is paired blood. Why aerobic and anaerobic? Because most pathogenic organisms are aerobes and facultative anaerobes. Therefore, they will grow in anaerobic bottle as well. Therefore, the more yield of the organism, that is one, the more volume of blood will be more yield, and therefore you will be able to give a faster report in terms of its growth as well. So, venous site is preferred. Catheter, we do not, our technicians, our phlebotomists do not take from catheter. It is done by the clinician from the central line or any other PIC line or other things. So, we get samples which are collected by them. So, we have 10 ml per bottle for an adult, which is final. So, we have a paired sample, 10 ml in each bottle, and they should reach the lab without delay. This diagram has been taken from the same journal that we said, that is QE Tech. 2% chlorhexidine now WHO has said is now the better skin disinfectant as compared to spirit, right? So, and when we were students, we had the spirit, iodine spirit, 3 times from the center to the periphery, not coming back to the center. We had by-hearted the whole thing also, and we were teaching everybody also. But today, chlorhexidine has changed the whole scene. Today, hand hygiene is chlorhexidine. Everything is 2% chlorhexidine. So please, this is something that we need to change here, because chlorhexidine 2% is used as a very good skin disinfectant. Most of our hospitals have changed to chlorhexidine completely, including for collections for even pathology or biochemistry or hemat also. So it's one skin disinfectant across the hospital. So it is alcohol based, it dries very easily, so you don't have to really wait, because iodine would take little time and then you had to wait, because otherwise it was not as effective. So you allow it to dry, as we said. So you need to wear sterile gloves. Sterile gloves, you need assistants to help you wear that. You have to have a lot of training for whoever is collecting blood culture samples. It is not going to be very easy on day one. So please insist on retraining and training for better sample collection. We actually have seen the difference. When we have the new person doing we train them, and after that we send them. But after that, even then we find that a lot of gram positives grow when the patient is otherwise normal. So that is when we are growing skin contamination, and blood culture paired sample is nearly 1200 to 1500. It's a very expensive test. So that is why we just cannot waste patients' money, because either you ask for another sample, so you have to pay, or you have to ask the patient for a repeat sample where they have to pay. So that is where we found that training and retraining has really helped in some cases. So it's a procedure which actually needs assistance. So similarly, do not refrigerate the bottles. When they come to you, please do not refrigerate. This was happening earlier when our ward people used to take it. They would refrigerate in the bottle, in the fridge, which we have now stopped that. So do not refrigerate even after inoculation. Please send them to the lab, and we will do it. We will do the needful. So please send them within stipulated time so that we can start processing. So raisins, all these new bottles are all with raisins, so we don't even have to talk about it. And this was at one point that we said. So the time of culture collection is very classical. So whether it is malaria, whether it is salmonella, the time of culture collection is of paramount importance, and that is when you have the peak. The fever peak is the time when you actually will go ahead and do a sample collection. So during this time now, the monsoons, we have a lot of patients now. For any PUO, we have a standard protocol. I mean, most of us are having standard protocols, isn't it, for PUO? So that's where one of them is blood culture collection. So please ask for a blood culture before starting empirical antibiotics, because that is the first dose that they will give in the hospital, especially IV. So before starting empirical antibiotics, you should ask. So not only timing, but volume is equally important. So, the more you have volume, the higher yield, as we said earlier also. So similarly, higher yield for the organism, faster turnaround time. So everything I think goes hand in hand. The faster yield and more yield is because of the right volume. This has been stressed in world across in terms of paired sera, in terms of sampling, in terms of volume and time. When we talk about set, we talk about 3 sets, especially when you have a PUO. A PUO, especially brucella. Brucella is a zoonotic infection where 3 sets are required. 3 sets divided between 1 hour each from 3 different sites. This is the standard protocol for any PO, but practically for Brucella. Brucella is a very fastidious organism. It's not that we don't have it. Zoonotic diseases are not gone. It is just that we haven't given importance to them, right? So, example Brucella. Infectious endocarditis. So what can we say? Infective endocarditis goes with the definition that you have, vegetations which are given in spurts. So you need to have multiple, samples for that, and fungemia, especially in the immunocompromised patients. So central line we do not take, but we have trained the staff that you need to, clean the hub, because that's where the organism sits for at least 15 to 20 seconds till it becomes dry, and that also with chlorhexidine. So do not discard any amount of blood, you can flush it back. So once the bottles come to us, we will load them in the blood culture bottles. All of us have got the similar systems. So when you have an agitated culture, it is faster yield for the growth of the organism. So all samples can be processed which are from head to toe, pleural, pericardial, ascitic, any aspirate from a closed area, from an abscess, can also be cultured in blood culture, because that is also a sterile sample per se. Many advantages of automated over, this was the slide when we were students, so that's how, automate. That time we had a lot of importance given to the back tech. That time biomery was not on the scene. So all of us were talking about backtech and BD and all those things that in our answers as well. So today with automated systems, there are a lot of advantages. A very important advantage in our hospitals that we find is because central line related bloodstream infections is one of the quality indicators for NABL, is one of the quality indicators for NABH. Being a quality indicator, a lot of importance has been given, and that we can be able to identify with DTP, that is time for positivity, more accurately with the automated system. So once you have a sample coming in the lab, all of us are doing the same. We do our routine primary smears, isn't it? With the primary smears now that with NABL that we have in the lab, a lot of importance is given to quality, and especially the control strains have to be checked with every batch. So we have it on hourly basis where we are doing the staining as well. Depending on the sample, you will put the culture on blood, chocolate, McConkey, chrome agar or dipstick as per the different samples that we receive. Coming to identification and sensitivity, is it important to identify up to the species level? Yes, because you need to identify whether it is a real contaminant like bacillus, or it is a commensal like skin flora, or it is a real pathogen, where you need to finally go ahead and do a sensitivity test. Microbiology is very colorful. We used to remember yellow to blue, yellow to pink, and green to blue, and what not colors. We had to write down short forms and acronyms when we were students, and eventually in the Viva table they would pick up something and ask us, and we would answer the other, because we just couldn't remember at that point in time. So right from the biochemical tests to today you have the array of tests which are done in these cards. This has really changed the scene in identification. Today all of us are following CLSI guidelines for the antimicrobial susceptibility testing and the interpretation. It is done for both disc diffusion as well as for MIC. So Kirby-Bart disc diffusion stands true even to date, but of course you have a lot of variables associated with it. Along with that, you also have to have a standard control which has to be used. The variables are, depending on the culture, you must have a Mueller-Hinton with anionic. The size of the inoculum, 0.5 McFarland, is very important, otherwise you can have discrepant results. Right from potency of the disc to storage to the entire list is there. So these are the disadvantages why most of us have gone to the automated system. MIC can be manual, but it is extremely tedious and time consuming, which is not practically possible in a working lab. So this can be a research project, but today that has also been taken care of by the automation, when you have the MIC as the minimum inhibitory concentration to then block the graded amount of drug with a standard inoculum size. E-test. E-test is commercially available. So we graduated from Kirby-Bot to doing an e-test to finally going to the automated system. So you have the graded drug, and then you are able to find out where is zone of inhibition, which is ellipsoid in nature. So this is actually done even today in most of the labs, especially for these high-end antibiotics which are used, especially vancomycin, colistin. This is where we are today. All of us have got systems similar to this. So the cards for identification and sensitivity have been used exclusively to help us with the right diagnosis, including we also are a part of EQUAS with CMC Vellore. There also they have either you have automated system or you have a manual system. So this is being able to help us there as well. So MIC, it is important in patients who are in the ICU, who have come out from the other hospital, who have had resistance to the empirical therapy, and that's where the importance of MIC. So you have higher the therapeutic index, better the choice of the drugs. All of this is in vitro study. May not always correlate with in vivo, even after automation in microbiology. So these PKPD, so clinical pharmacologists will help us understand the PKPD, AUC, area under the curve, versus PAE, which is the post-antibiotic effect. The last couple of slides. Where are we moving ahead and where are we here? We are here up to the BioFire level, where you have a syndromic approach. So from the clinical specimen, you can have an array of tests and identify bacteria, fungus, virus, parasite, all of them. Haynes test or the line probe assay or Gene Expert Ultra have now graduated to become the next level for Mycobacterium tuberculosis in particular, but many other diseases as well. So you have swine flu, you have viral load, which can be done by this, you have carbapenem resistance, as well as C. diff, because C. diff can be one of the quality indicators for the wrong antibiotics that we are giving, because it causes antibiotic associated diarrhea. Finally, PCR. PCR is an open system as well, so you can do a lot of things in PCR. A whole lot of virology is there which is being done in PCR today. So the last slide, the take home message is that integrated lab, we are a department of laboratory medicine where we all are one. Communication with the clinician, I think, is of utmost importance, because without that we would not be able to give the right reports without understanding the history and a dialogue with them. Today the cases have become more complex. You had transplant, you have other infections, they have become more complex, which require more accurate diagnosis and a faster turnaround time as well. In the era of evidence-based medicine where we are today, the patient can sue us for giving wrong antibiotics for wrong identification of the drugs, of the organisms. So that's where we are today. This is the 21st century. And Dr. K. Ramamurthy was our professor in medicine, a very renowned person. He used to tell us this, that unless you have the attitude to learn, make mistakes, keep learning, say sorry, again work on that, then only you can soar the skies at high altitudes. Thank you so much for your kind attention.